Hi, I'm Raphael, and this is Ask Me Anything for today, the 18th of September 2020. Bridget asks, Hi Raph, I've been going over your paper on diastasis recti, that's abdominal separation, and wondering if you could further explain the hollowing effect. Quoting from the paper, to reduce diastasis, do curl-ups or any resisted abdominal flexion. Make sure not to hollow the abs, as this makes the exercise ineffective. What exactly are the hollowing exercises? Does it mean pressing your back to the floor while doing exercises such as double leg stretch and 100? And if that's the case, then I'm presuming you would avoid these exercises in the first 12 months after giving birth, or just avoid hollowing while doing them. I'm assuming any of these rules more apply to the first 12 months after giving birth, as beyond this there is no further benefit to help reduce diastasis. Thanks again for your help. Cheers, Bridget. Well, Bridget, great question. And in fact, I'm just in the process of rewriting that paper. I wrote that maybe 2 years ago now, and it's got a little bit out of date. And the actual quote that you brought up, so make sure not to hollow the abs, as this makes the exercise ineffective, is actually incorrect. So one of the things I'm doing in the rewrite is I'm taking out that statement. Hollowing in the literature is essentially refers to not like a hollow body, like in the gymnastics where you kind of do a hollow body shape, like a pressing your low back towards the mat. That's not what they're talking about. It refers to drawing in of the abdomen. So contracting your transversus abdominis, sucking in your belly button towards your spine. That's what they're talking about. That's what I was talking about. I want you to just wait maybe sometime in the next week. I should have this thing done, and I will distribute it to you. Thanks for picking that up. Camillo says, Hi Raph, how are you? My name's Camillo. I'm in the Cert 4, haven't introduced myself in the lectures, loving the course, and so glad and proud to be a student of BE. Well, we're so glad and proud to have you, Camillo. Thank you. I wanted to pick your mind regarding reformers and a bit of business. As well as studying to be a Pilates instructor, I'm a professional figure skating coach as well as current athlete. As I work at an ice skating rink based in Reservoir, surrounded by athletes, I've been given the approval by the rink's owners and management to run mat and reformer classes at the rink once they open again. I wanted to pick your brain on which type or brands of reformers do you recommend to purchase for a small studio inside an ice skating stadium. I'm planning to buy one reformer until I have enough finance and customers interested in reformer classes to purchase more reformers. Your expertise would be greatly appreciated. Thank you, Camillo. Well, Camillo, I'm going to smoosh that together with a question I got from Tegan, which is very similar. Tegan says, Hi, Raphael. I'm sure you've had this question a million times. I'm looking at purchasing a reformer for at home. What should I be looking out for? Do you have any recommendations? Thanks for your time. Well, Tegan, and well, Camillo, your questions are similar, but I'm going to give you a slightly different answer. So if you're looking for an at-home reformer, the considerations are a little bit different because you probably want something that's going to take up less space and maybe fold so you can store it under your bed or in the cupboard. And you're not going to be using it commercially. So, in other words, it's probably just you going to be using it, or maybe if, your mum or a friend or whatever. But if you're for Camillo, somebody who's considering using it commercially, ideally you're going to have like 5-6 people a day on it, 5 days a week. So it's going to get a lot heavier usage. So for an at-home reformer, there are a number of ones that are available, but actually we have just partnered with Pilates Health Equipment, which are an Australian designer of and manufacturer of Pilates equipment. We use all their equipment at our Northcote campus. We've just partnered with them, and they have developed a at-home folding reformer that we are able to now offer our students, and we're just about to release this in the next week or so, only for current students, to for $1,500 delivered. So that is like at your doorstep for $1,500. That includes a mini box and a foot bar, and I think it also includes a jump board. So that is by far the cheapest at-home reformer you'll find, and that it will be available for current students. That will be available for students in the October and onwards intakes within the next week or so, and then it'll be available for students, current students who enrolled prior to the October intake within a few weeks after that. So I would recommend keep your eye on our website, and we'll send you out an email also, Tegan, to let you know as soon as that's available. And Juan, Camilo, I would recommend you definitely need a commercial reformer. There are lots of good brands. I love Pilates Health Equipment. We use them at the studio. I know Chloe uses Align Pilates. She's got a reformer at home. We've used Stop Pilates ones with great success in the past. There are a bunch of really good brands. I think the key thing is you want a commercial one. And my recommendation would be look for a good quality used one. I think in this post-COVID, as we emerge from lockdown, there are going to be some businesses that are doing great, and there are going to be some businesses that are going to be closing down, and there'll probably be reformers on the market. So I would keep your eyes peeled for those on Gumtree, on eBay. I would go to Breathe Edu Students Facebook group, etc. And I would imagine that there'll be some kind of secondhand market for those. You should, I think, if you end up buying brand new, if I'm wrong and there's not a lot available in the secondhand market, I think you really can't go past the Pilates Health Equipment ones in terms of value for money. On a super robust machine, you'll pay about, again, I haven't looked at their website recently, but last time I checked, they were about $3,500 for a commercial grade metal-bodied reformer. That's the brushed aluminium ones that we have at Northcote, and they're super robust, and they will last you, years or decades. And for most of the other brands, you pay considerably more than that because they're imported or just more expensive. And for some things like a leg raise, you can pay up to like $6,000 for one reformer, so like almost double. So I think you can't go wrong with most commercial brands. Make sure it is a commercial reformer that you get, though. Secondhand's good. If you buy secondhand, have a go on the reformer first. Don't just buy it sight unseen. Get on it and do a full workout. Make sure it doesn't squeak or creak or groan or moan, that the carriage travels smoothly. Have a look at the ropes. Make sure they're not frayed. Pull on all the springs. Make sure all of the springs have roughly even tension on them. None of them are stretched. Look at the fabric on the upholstery. Make sure it's not cracked on the headrest and the shoulder pads and so forth. So that's my advice. Hope that helps. Shanae says, "Hi, Raf. Hope you're well. I have a question about dislocating your knee. I teach dancing, and one of my students dislocated her knee last week just in a lunge stretch. She's seen 3 different specialists, and they all told her that she has to have surgery to get her ligament pinned back or something, otherwise she would keep dislocating her knee. Is surgery the only option for dislocating? She's only 13, so I thought maybe there might be another option for her." So from what you say, I can't be certain, but my assumption is that you're talking about a dislocation of the patella, which is the kneecap. And so the kneecap is held on by strong ligaments on either side, a medial ligament and a lateral ligament. Medial is towards the inside of the knee and lateral is towards the outside. And they're called the medial patellofemoral ligament and the lateral patellofemoral ligament. And then the patella also sits in a little groove inside the femur, the thigh bone, called the trochlea, and it slides up and down. And most commonly when it dislocates, you didn't say what was the case with your client, but most commonly when it dislocates laterally. So it slides laterally. And so that means that the medial patellofemoral ligament is stretched. And sometimes that can be because people have maybe just, through random genetics or whatever, a more shallow trochlea, a more shallow groove in the femur so that the patella doesn't sort of sit as deep, and so it's easier for it to dislocate. And sometimes it can be for other reasons. So I did a bit of a literature search, and what I found was that for skeletally immature people, people of the age that your client is, you're talking about, she's 13, she's still growing, her skeleton hasn't finished growing yet, that for first dislocation, if this is the first time this has happened, she's got a pretty good chance that it won't happen again. Whereas if it does happen again, after they dislocate the second time, it becomes very likely that it will remain, continue to dislocate. It will become unstable, basically. At which point, surgery to repair the medial patellofemoral ligament is probably the best option. And that's what I found in the literature. So my recommendation would be, based on that, strengthen her leg, avoid, whatever position it was that she was in when she dislocated it for a little bit, and then gradually move her back towards that over, the next maybe 2 to 3 months. Strengthen her leg, her quads, her hamstring, just do lunges and squats and those types of things with her. And if it doesn't dislocate again, great, no further action required. But if it does dislocate again, probably I would agree with the surgeons that surgery is probably the best option. And if this is not the first time that it's happened, if it's happened previously, well, then I would probably agree that surgery is the best option. So hope that helps. Okay, Stephanie says, hi Raf, just a quick question for your next AMA. I have a client that often gets pins and needles in her sacral area. It only occurs when she does side-lying exercises such as clams, double leg lifts, side kicks, etc. She can usually get through 3 to 4 minutes of side-lying series before the pins and needles start, and they go away once we stop and stretch. Just wondering if you have any ideas as to why this happens and should she be concerned? Thanks, Steph. Well, Steph, I don't think she needs to be concerned, but I will just mention that there are a number of signs that, when combined, can indicate a problem with the lower spinal cord. And it's called cauda equina syndrome when that happens. And one of them is called saddle numbness. And so that is numbness in your saddle, which is the bit of your butt that you sit on. So when you're sitting on a chair, it's the bit that's on the chair. Now, that doesn't sound like what you're describing. What you're describing, you said her sacral area, which is a bit higher up. So I don't think that's what you're describing. But just to be super clear, if she's feeling... Now, you described tingling, which is a different thing again. So if she's feeling numbness in the part of her buttocks that she sits on, she should go see the doctor about that. That could be potentially something serious. Whereas if it's truly a tingling and it's truly on her sacrum, which is not her butt per se, then it's not related to the cauda equina, the lower part of the spinal cord. And I did do a bit of a Google search and found a couple of articles referring to, it's probably the nerve root that comes out from S4, which is the second lowest part of the sacrum. But I couldn't really find anything definitive on that. And so I'm just going to have to say I honestly don't know. Unless it, if it's not saddle numbness, it's probably nothing really to be concerned about. But I'm sorry, I don't have a ready answer for you. And a half hour on Google Scholar didn't make me much the wiser. So I'm sorry I can't help you with that. But I guess my advice is if it's not saddle numbness, probably don't worry about it and limit your sideline series to no more than 3 to 4 minutes. Sorry about that, Steph. Thomas asks, hi, Raf. Mate, in the shoulder you mentioned the rotator cable, which is so cool. Tell me, is that what gives way when you dislocate your shoulder, and is that what they fix in surgery? The rotator cable is super cool, and I'm not going to go through a description now of what the rotator cable is because that is almost a full 90-minute anatomy lecture, but I will talk about what happens commonly, not universally, but commonly when people dislocate their shoulders. And this is what happened to my wife, Julie. So the shoulder joint consists of the socket, which is part of the scapula. Okay, so this is the scapula, the shoulder blade. This is a side view we're looking at. And this is the socket here. And there is a lip of cartilage. Let's see if we can add a layer here. There's a lip of cartilage that lines the socket. There's some cartilage that lines the socket like that, and where that lip of cartilage protrudes beyond the joint there, that is called the labrum. Just the lip of cartilage that protrudes right at the edge of the shoulder socket. Then, of course, you have the arm bone, which is called the humerus, and that has a ball on the end of it that looks something kind of sort of like that. That is called the humerus. That's the arm bone. And the shoulder joint is held together by a bunch of ligaments and the joint capsule. And the joint capsule is just a ligament, which is to say that it is a sort of a structure that goes like that. And is attached to the head of the humerus and also to the labrum. It's attached to the head of the humerus and the labrum. And so that, and there are some other ligaments involved, but most of them actually are part of the joint capsule. And so the joint capsule at one end is attached to the humeral head and at the other end is attached to the labrum. Now, what can happen when someone dislocates is that the labrum can actually come off the scapula. So let's see if we can move that. So and this is what happened to my wife Julie, that her labrum detached. Kind of like that. And so now you have the labrum detached here. And so the joint capsule is also detached, which means there's nothing holding the humeral head, or very little holding the humeral head in the socket. So what they repaired in my wife was and this is called a Bankart surgery. I think that's how you spell it. It's something pretty similar to that anyway. Where they basically go in and they put a screw in, and they put a bunch of screws in. In my wife, they put 5. They put a screw in, and then they put a little stitch in there, and they pull the stitch tight, and what that stitch does, and then they pull it tight, and what that does is it pulls the labrum back into contact with the joint surface, with the bone of the scapula. So it just tightens it back down again. And then sometimes what's also happened is that this ligament, the joint capsule, has stretched. As part of the femur popping out, it has stretched a bit, and so what they can sometimes then do is they fold it over. So basically, if it's a long, structure like that, they get it and they just fold it back on itself, and then they staple through it, okay, and staple it down to make it tighter. So they might, nip and tuck through there and make all of that tighter. So that's what they do commonly, and for shoulder dislocation. And the Bankart surgery is a very successful procedure. There's way more than it's something like a 97% success rate of preventing any further dislocations. So that's a really good surgery. If the problem that's causing the issue is that the labrum has detached, which I believe it is commonly the case. So I hope that answers your question. Caroline says, "Hi Raf, loving anatomy so far. Thanks for putting the series together in such a concise way. In Anatomy 1, Lecture 2, you refer to a survey of 450 clients regarding what they consider to be important in a Pilates instructor. I was wondering if you would have any links to that PMA study, please. I've done a quick Google search, but I'm not sure I've found the right one here. Is that the research you're referring to? Thanks in advance." Well, Caroline, I followed the link you provided, and no, you didn't find the right one. You found an older document from 2012. And what you're looking for is this. It's called the PMA. Pilates in America study, 2016. And there it is. In fact, we've actually got a blog post about it on our blog. So let's go to our blog. Pilates in America study. There it is. You'll download it. So if you want to find it, you just go to our blog, breathe.edu.au/blog, and you type in Pilates in America study into the search box there, hit enter, and Pilates in America study. Well, that didn't really give us what we wanted. Well, it insists on giving me the wrong blog post, so all right, I guess it's back to regular old Google and just type in PMA Pilates in America study, and I will go and figure out why the search function is not working on our blog for that item. So it's a Pilates in America study, and when you open it up, it's got a nice green and blue cover with the map of the US, and it's a PDF that you can download for free, and it's got all of their what their findings were, results, etc. So it's got some pretty interesting information in there, and I hope you find that useful. So, thank you for that question, Caroline. Next question comes from a student who wishes to remain anonymous. Hi, Raf. I hope you and your family are well. Thank you for these AMA. I've found them interesting and beneficial. My pleasure. My question is, do you think PRP treatment is a good choice for tennis elbow? PRP is a abbreviation for platelet-rich plasma. So it's basically, platelets are the cell fragments that circulate in your blood that basically cause blood clotting. So when you have a wound, that causes blood clotting, and plasma is the fluid that makes up your blood without the blood cells in it. So plasma is basically water with a whole bunch of proteins and things in it. So it's basically platelet-rich plasma is basically they get some of your own blood, distill it down, and inject it back into the site of an injury to stimulate healing. My story. I've done some research and the treatments for tennis elbow have been basically more research is required. Yep, sounds like you've found what we know about tennis elbow. My story. I work 40 hours a week at a desk purchasing product which involves a lot of repetitive movement. I'm 45 years old. Back in August 2019, I developed tennis elbow in my right arm. Tennis elbow is also called lateral epicondylalgia. So it's pain on the lateral epicondyle, the outside bony bump on your elbow, and algia just means pain. So it's lateral epicondylalgia or lateral epicondylitis. I think algia is the more current term. And so it's normally pain that's associated with bending your wrist back or flexing your wrist. And it's called tennis elbow because when you serve in tennis, you do that action, but it's not just limited to tennis players. A lot of people get it. The treatment for this was physio 2 times a week and exercise through an exercise physiologist. Then in March, I developed tennis elbow in my left arm. I tried a cortisone injection in the left, which lasted about a month. The right elbow is now 90% better. The left has improved since March, but I continue to have large flare-ups and I'm over it, understandably. I've seen a surgeon and he had a recommendation. He recommended a splint, to which I said no, as I felt this would then affect my other muscles, causing weakness. I didn't feel this was a good option. He then recommended the PRP and 4 weeks off work. I continued to see a physio and EP. I've found with this injury it's like taking 2 steps forward and 1 step back and a very slow recovery. It's very frustrating, so I'm seriously considering the PRP as my understanding is that it could fast track the healing, or do you think time and strengthening is the healer here? Would really love your thoughts. Thanks. Well, I did do a bit of looking and there's a fair bit of literature on PRP injections for lateral epicondylalgia. And literature that I've seen compared it to cortisone injections and saline injections, and by and large has found it to be superior. So and that was maintained at 1 and even 2 years follow-up. So I'm going to say, give it a go on the PRP for lateral epicondylalgia. And unless you really want to, don't take 4 weeks off work. That sounds like a bad plan. And keep strengthening it. And if anything aggravates it a little bit during movement, don't worry about it as long as it settles within a day. But if you do something that aggravates it to the extent where it doesn't settle within a day, we'll just tone it back a bit with that particular activity to the level where the pain settles within a day of doing the activity. But don't stop doing stuff like working or anything. But yeah, go and get some PRPs and let us know how you go. Miko says, "Hi Raphael, thank you for reaching out to people with your informative podcast each week. I'd like to ask you a question. My apologies in advance if you already have covered and spoken about this subject. Adenomyosis. Miko, I have never spoken about this subject, so thank you for asking. So I'm 48 years old and my uterus wall is enlarged. Ultrasound says it's 950 millilitres in size and taking up my abdominal space, pushing my bladder and feels like causing pelvic tilting. I need to watch out for maintaining good circumstances so that my uterus tissue doesn't rot and making sure that my uterus doesn't press on the kidneys and damage them. Would you see benefits for me to take up Pilates with my condition, physically and also hormone balance-wise? If yes, do I need to see a special Pilates specialist, or any practitioners could assist me with my stiff belly, or join a class with pregnant ladies? Any advice would be much appreciated. Thanks for your time. Kind regards, Mickey." Mickey, what a great question, because I had no clue what adenomyosis was, and I had to go and look it up. And so it turns out that adenomyosis is kind of related to endometriosis. The endometrium is the inner lining of the uterus. So the uterus has 3 layers of muscle, and the endometrium is the inner lining of muscle of the uterus, and it's the inner lining of the uterus, and the middle layer, the muscular layer, is called the myometrium. And adenomyosis is where there are growths of inner uterine wall tissue within the myometrium. So there's like uterus lining growing within the muscle part of the uterus. And that's similar to endometriosis, where the endometrial tissue, the uterus lining tissue, grows outside the uterus in the abdominal pelvic cavity. And so basically, a bit of a Google Scholar search, Mickey, didn't uncover anything in relation to exercise and adenomyosis. There were plenty of studies on surgery and hormonal treatment, and I imagine you've looked at many of those options, but so hormonal treatments, and even they embolize so they basically inject little microscopic glass beads or plastic beads into the blood vessels that feed the tissues that are, the endometrial tissues that are growing inside the myometrium, and that can cut off the blood supply and cause them to shrink. So there are a bunch of surgical and hormonal treatments. I didn't find any exercise literature at all. And so, based on what I've read and my understanding of the physiology and anatomy of the area, I would say probably movement is going to be good. Now, whether it's going to do anything for your condition, I would be skeptical about that. I would think you're probably not going to improve your condition through exercise, but exercise has so many other benefits. So it's going to improve your general health, your mental health. It's going to, help you with weight maintenance and cardiovascular, disease prevention. It's going to help with cognitive function. There are so many benefits to exercise. You should absolutely be exercising. Pilates in particular, you should definitely do some form of strengthening and stretching. And if you like Pilates, do Pilates. Should you do that with somebody clinical? No, I think you should just go and do a regular class. And I think you should just maybe start with a beginner's class and, let the instructor know that you have this condition and that sometimes you get, discomfort and stiffness and pain. And, if you get a bit of pain, don't be alarmed. If the pain feels intolerable, I would say stop and ask for, hey, can I do a different version? Or just reduce the range of motion or the effort level, put on fewer springs or drop to your knees or something to make it easy enough so that the pain's tolerable. So that would be my general advice. But like I said, that's kind of just based on my opinion and background understanding, which is not a good thing to base expert advice on. So I guess I guess that's the best advice probably that's available in regard to exercise, because I don't think there's any literature on it. So I guess go do some exercise, and if in terms of treating the condition though, I don't see exercise as part of that picture, but there seem to be plenty of medical treatments available. I imagine you've already looked into those, but if not, go talk to your doctor. Hope that helps. Well, that's all we have for today. Thank you, everybody who put in questions, and thanks to all of you listening or watching this. It gives me great pleasure to root around in Google Scholar and try and find answers to these questions. And I hope you find them helpful. If you have questions, I'd love to hear from you. Whether or not you are a student of Breathe Education, past, present or future, matters not. I'd love to hear from you. If you have questions related to Pilates, related to business, related to anatomy, physiology, biomechanics, injury rehabilitation, those are the things I know about, and those are the things I can also go and find out about if I don't know the specifics. So, love to hear from you. You can email me, raphael.b@breathe.edu.au. I hope you're well, hope your loved ones are well, and I look forward to seeing you next week. Ciao.